Hello, and welcome to today's webinar, Coordinating Care for Kids, School Nurses Linking with the Medical Home, presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. My name is Stephanie Muha, and I'll serve as your moderator today. I'm the staff lead on initiatives related to children and youth with special needs at the American Academy of Pediatrics, and I also work closely on the National Center for Medical Home Implementation activities that are specific to this population and their families, including today's topic, care coordination. Just a few things to mention before our faculty begins. Your slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions by using the question box window at the left-hand side of the screen. These questions will be answered at the end of the presentation, and if we don't have time to answer them, we will send you an email with the answer. This webinar will be recorded and will be archived on our National Center website after this presentation. After the webinar, you'll also receive an email with a link to the evaluation and additional resources that will be mentioned on the webinar. We encourage you to complete the evaluation so we can continue to improve the content of our presentations in the future. Just some of the disclosures that today's presenters have no financial or conflict of interest disclosures to announce. Today's webinar has 4 learning objectives, and by the end of the session, we'd like you to be able to do the following. Describe the role school nurses and school health teams play in meeting the comprehensive needs of pediatric patients and families. To identify clinical guidance, curricula, tools, and resources that facilitate pediatric care coordination implementation. Provide some examples of practical strategies that you'll hear from the speakers and processes to implement effective pediatric care coordination between school health and medical communities. And finally, identify care coordination models that demonstrate partnership and collaboration across multiple care systems. Now I'd like to introduce to you today's first speaker, Dr. Diane Baker. Dr. Baker is a professor at the School of Nursing and directs the School Nurse Credential and Master's Program at California State University, Sacramento. She's a faculty member at the Center for Excellence in Developmental Disabilities at the Mind Institute and volunteer clinical faculty in pediatrics at UC Davis Medical Center. Dr. Baker obtained her PhD from the University of Hawaii and completed postdoctoral research fellowship at UC Davis. Her research on school roles in systems of health for children and youth with special health care needs was published in Journal of School Nursing, and an article on school nurse care coordination is soon to be published in the NASN School Journal, or School Nurse Journal. I've been fortunate to work closely with Diane over the past several years on school health activities, most notably the curriculum that you're going to hear about today. Dr. Baker.
Thank you, Stephanie. You can go ahead and advance the slide. So thank you for joining us today, and I think that this web of services demonstrates very nicely why all of us in the healthcare community need to partner with parents and families to talk about care coordination at a systems level. This is one parent, Kristen Lynch. She has a fabulous website. It's down there at the corner for you. There's lots of tools for parents. And this is her Child with Special Health Care Needs Services web. All the things that happen for her at school are up there in the red. The blue is down in the lower left-hand corner. The community services are over to the right. And you can only imagine what this is like. And if we're all disjointed and not in any way helping the family with their care coordination, this is what it looks like. Go ahead and advance the slide. Thank you. So care coordination, its time has come. Everybody's talking about it. All the professional organizations are moving forward. The National Association of School Nurses came out with their framework for the 21st century for school nursing practice, featuring care coordination as one of the essential components of the framework. And what is, I think, really notable about this is that it's moving the concept of care coordination beyond individual case management, but really looking at it as a systems issue. How do school nurses need to think about their leadership role as a manager of systems for children rather than just the individual student? In addition to this, the Centers for Disease Control and Prevention and the Association for Supervision and Curriculum Development published a new framework, Whole School, Whole Community, Whole Child, that emphasizes care coordination across systems and particularly including community resources. And the American Academy of Pediatrics and U.S. Maternal Children's Hospital also tells us that we need to be talking about care coordination. I point this out also because I think it's helpful, particularly for school nurses, when they're beginning care coordination discussions in their district, to get on the website, bring in this information, and talk about this as a national trend. Next slide. And then, so exciting, on Monday, the American Academy of Pediatrics released their brand new role of school nurse in providing school health services policy statement. I had 5 emails from reporters right after this was released asking for interviews about this. And one very sentinel statement they made is the call for a minimum of one full-time registered school nurse in every school. But that school nurse will be providing care for students, but also go down to the third bullet. An essential role there is the collaboration and care coordination at systems level with pediatric offices, with community providers, and finding new mechanisms for us to share information across systems, including the electronic health record. Next slide. So why is everybody talking about this? We actually have evidence-based research that demonstrates 4 findings that are of interest, I think, to school systems, health systems, pediatric offices, but most importantly to families. Families and students get improved access and ability to navigate school and community services. And if you think back to our first slide with Kristen Lund and her family, you can only imagine the benefit. And here's something we often don't think about, but school health teams and pediatric offices experience an enhanced job satisfaction. And when you're making your workforce happy, there are multiple benefits across the system. Families and students actually get enhanced self-advocacy skills because they can begin to navigate and negotiate the system in a much more fluid way. And important to all of us, students will be in school healthy and ready to learn, and there are multiple studies demonstrating when we are effective at care coordination, we can improve school attendance, which of course is the key to getting your high school diploma. Next slide, please. So how are we going to do this? So this is a model that's developed to look at the systems level and the school nurse role in leadership, organization, and monitoring of care coordination. This model is going to be published with detailed information about all these things in the NASN School Nurse, the School Nurse newsletter within the next few months. But taking a look at number 1, school health teams and support. Clearly identifying who are the members of your school health team, including administration, families, and students. And this may even include somebody representation from transportation and the other types of services that happen at school. So you can begin to communicate in a systematic way about students and family needs. Number 2 is the interagency partnership and the link to primary care. This is such an essential component so that the medical care home, knows and understands what the school is doing. The school can understand what the medical care home goals are for health services. And when problems and issues come up, you can discuss them and negotiate them in partnership with the family. But what is often missing in this is actually a formal agreement, a memorandum of understanding, so that each party knows and the roles and expectations of the other party. Issues such as HIPAA and FERPA are dealt with, and the lines of communication are open. Number 3 is surveillance and tracking, and so this is so you can look at a systems level and begin to really know what the outcomes are for students and families related to care coordination, and of course using evidence-based guidelines. The important and key thing about evidence-based guidelines is that you make it explicit and clear which evidence-based guidelines you're using, cite them and note them, so that all members of your school health team and your interagency partnerships know what evidence-based guidelines you're working on, and also that you time the evidence-based guidelines for review and renewal, so you're not using outdated guidelines. And number 5 is performance improvement and outcome evaluation. And this is really monitoring the overall impact of care coordination across both systems and using common metrics to know that things are getting better in care coordination with families. The school health team should ideally be led by the school nurse and looking at common goals across systems and discussing things like FERPA and HIPAA. These do not have to become barriers. We have good news that Health and Human Services and the Department of Education are going to be issuing some new guidelines to help us with HIPAA and FERPA. But you do need to monitor how are things going, are we meeting our goals, and what are the next steps to improve services for students and families. So you're looking at it at a systems level. Next slide, please. So a set of tools and curriculum have been developed and are available for you. Myself and Jody Johnson, who you're going to hear from in a few minutes, have set up a series of tools that include forms, guidelines, report to physicians, SBAR tools, etc., and curriculum. Next slide. The 3 modules and lesson plans on care coordination, looking at it at a systems level, are how a school nurse can implement care coordination, how school nurse and care coordination supports students with ADHD, and that's really meant to be just a test example. And then health-related services, which focus on social determinants of health and community resources and coordination within that domain. Next slide, please. So here's how it can work. There are multiple barriers towards setting up care coordination, and our big go-home message today is just get started. Find the opportunities where they are. Find that one medical care office. The medical care home can find that one school nurse and just get started. For example, Robin Cogan in New Jersey, who's a Robert Wood Johnson School Nurse Fellow, set up community cafes by partnering with her local Academy of Pediatrics Association and invited parents and pediatricians to get together and talk about school health. And she's had great turnout and is really moving the entire community forward in partnership with the medical care home in her community toward care coordination. One of the school nurses that completed the care coordination curriculum partnered with her large pediatric triage hospitals. And rather than just wait for the student to show up after hospital discharge, they set up signing HIPAA FERPA forms, put a care coordination together, did shared care planning with the family, and things were all set by the time the student ever returned to school after a complex hospitalization. And next, you're going to be hearing from Jody Johnson, also a Robert Wood Johnson School Nurse Fellow, and her way that she was able to move her community forward. Thank you.
Thank you, Dr. Baker. Now it's my pleasure to introduce our second speaker, Jody Johnson. Ms. Johnson has spent her entire nursing career in community health nursing in rural communities. She earned her bachelor's degree in nutrition and dietetics prior to becoming a registered nurse. She has been a school nurse for the past 25 years and has been on faculty of California State University, Sacramento in the school nurse program and worked with Dr. Baker on the development of the curriculum. Many of her summers have been spent as a camp nurse working with children on the autism spectrum. This summer, she looks forward to touring the East Coast with 17 and 18-year-old youngsters challenged by autism who are learning life skills and touring college campuses. Ms. Johnson has a master's degree in nursing health leadership from UC Davis and is a Johnson & Johnson School Nurse Fellow. Ms. Johnson.
Thank you, Stephanie and Dr. Baker. It's an honor to be here with you all. So, how do we better communicate and collaborate between schools and the healthcare communities? Advanced slide, please. We know that there's a dramatic increase of chronic health issues that challenge our children, such as asthma and ADHD and type 2 diabetes, just to name a few. Clearly, these conditions affect the ability of a child to learn, to focus on school, and their rate of absenteeism. Often there's not a formalized model or system to communicate student health needs between the school, parents, and community health care providers. In our local community, the nurses were feeling that communication was less than effective. We know that a major role of the school nurse should be as care coordinator, a person to bridge the gap between the medical community and schools, and that this role needed to be more clearly defined in both camps. Next slide, please. We decided that school nurses are in an ideal position to promote early identification of possible health problems. We can collect and share important information, data, with our healthcare providers. We can educate the parents and staff and monitor and reinforce prescribed treatment and management of healthcare conditions. And we can bridge the communication gap. Advanced slide. In our local community, it was decided that in order to improve our system of care, we would start by addressing one chronic health issue, and that was ADHD. This came from a focus group where parents and staff and local healthcare providers all got together and decided that this was a primary concern. So as our time is limited, I'll refer you to the model and toolkit provided in the resources mentioned by Dr. Baker. But to test the tools, we initially applied to, address ADHD. So we were looking at early identification and classroom interventions. We were looking at data collection and the school nurse as being the point person to collect data and consolidate it. And we were looking at identifying a target person, a point person at the pediatric office or the primary care provider's office who could assist in facilitating the information and getting it to the doctors. Advanced slide. One of the challenges our school nurses were confronted with after collecting and gathering data and sending it on to the healthcare providers, it seemed that the information was just not getting used. So we went to the source and we requested a meeting with our local doctors. And we sat down at lunch together and I asked them directly what they needed. The answers were pretty clear. Yes, give us information to help us understand what these children need, but make it concise and provide your nursing recommendations up front. It was decided that the SBAR, the Situation Background Assessment, and recommendation format, which is a form of notation used in hospitals and clinics here locally and in many places in the nation, could be adapted for use by the school nurse. It would provide a recognizable form of communication that was concise and to the point. A sample is in the toolkit in our resources. Additionally, the doctor's committed to assigning a point person in their office to work with the school nurses in communication. So, follow-up. This seemed to be a big area where the ball was being dropped. Following diagnosis, our job was clearly not done. A step-by-step process for assessing treatment efficacy was developed. Again, we tried to keep a clear communication path in mind between teachers, parents, and healthcare providers, using the school nurse as the gateway to provide feedback for the entire team. Advanced slide, please. So I'm going to make this case study short, again in the interest of time. Sean was a 7-year-old boy when I met him, who by all accounts is very bright. However, he was not making academic progress and had lots of social peer issues. His parents were worried, his teacher was worried. The first hint that the care coordination concept that we were working on was gaining credibility was when I was invited to observe him in the classroom and on the playground. Behaviors observed were fidgeting, blurting out, difficulty redirecting, constant motion, and annoying other children with his lack of understanding of personal space. Again, for the sake of time, I won't go into all the educational interventions that were applied following a student study team meeting. In the end, a recommendation to the parents was made that they follow up with their primary care provider. I, as case coordinator, followed the process. I assisted in collecting diagnostic screenings, the Vanderbilt screening, the school psych reports. I consolidated parent and teacher information. And then I completed the SBAR and sent it on. I also contacted the point person at the physician's office who assisted us in setting up an appointment to see the doctor. There was some concern that the parents would have difficulties following through. They just were pretty overwhelmed and the household was a bit chaotic. After a diagnosis of ADHD, medication was prescribed. After some more tweaking of meds and a strong behavior support plan, Sean slowly became more successful. Counseling was arranged through our county mental health program, and communication on his progress was being shared. As Sean has become a preteen, we continue to monitor his progress and keep open communication between the healthcare providers, parents, and school, as no doubt puberty will impact his treatment plan. Next slide. Are we coming up with the next slide?
Yeah, it's up on our end.
Oh, okay. So the results of applying an organized systematic approach has allowed for improved coordinated response to students with chronic health. We have now started to apply the tools developed to other chronic health issues such as type 2 diabetes and asthma. Some of the lessons learned can be applied in many areas of communication with community health providers, including county mental health and public health. We've even started doing more coordination with our emergency room department. We find that teachers and staff feel supported in their health concerns for students, that parents feel more supported, and that our job satisfaction is increased due to the leadership role we take in improving the health care of our students. The main question I'm asked as a school nurse is, how do I find the time to take on this role? And I have found that while up front the process does take quite a bit of time, in the end it has saved time due to increased efficiency and improvement in overall student health. Thank you.
Thank you, Ms. Johnson. Our next speaker is Dr. Mark Satterfield. Can I ask all the speakers to mute their phones? Well, that was interesting. I didn't want to hear myself on a screechy loop like that, but hey, had a little rhythm to it.
You know, I may have fixed it by muting my phone briefly.
Yeah. Always a glitch. Thanks, everybody. See, this is real life. Anyway, so our next speaker is Dr. Mark Satterfield. He is a family physician and health officer for Plumas County in Northern California, where he's practiced medicine for 25 years. Achieving quality integrated care for children from rural areas has long been one of his long-term passions. He helped to bring emergency pediatric telemedicine to rural Plumas County and helped to improve access to pediatric specialist consultation in the area. He continues to work closely with Jody Johnson and others to improve the integration of child's health care between school nurses, emergency department, the clinic setting, and public health. Dr. Satterfield.
Thank you very much, Stephanie, and thank you to both Diane and Jody for their earlier comments. It's been a pleasure so far to be a part of this presentation. So I'm here to offer somewhat of a rural physician perspective to this. Our community has a population of about 3,500 people and draws from a surrounding area of about 10,000. We have many of the challenges similar to other rural areas. Most of the child health care is provided by family practitioners. Pediatricians have come and gone, usually after a year or two in practice here as a solo provider. So the landscape is not very favorable. So as many of you know, one of the keys to being an effective family practitioner is to know your limits. And special needs children are particularly problematic because of the depth of their often complex problems. So I want to just start off by picking up on the care coordination theme that's been central to our discussion thus far. It's great to have such excellent tools being developed and being presented to help facilitate this going forward. One of the main things I'd like to offer isn't interpersonal communication so often the key, but it takes so much energy and commitment of time. These are precious commodities in our busy times, of course. It seems to me that if we can just get good communications going between our school nurses and the pediatrician or the FP, the rest does tend to fall in place, especially if you have excellent tools to work with. So what's our key to good communications? Well, you know, getting to the first slide here, one of the most important seems to be having a champion leading the charge from the various disciplines that need to have effective communication. And too often there may even be an individual in a group that would step up but maybe doesn't even realize how important it could be for them as an emergency physician to get a dialogue going with the school nurses or with mental health regarding children's health. So I've listed here some of the numerous agencies that, of course, need to interact for effective pediatric coordination of care. But the interpersonal communication is obviously one of the keys. And the champion has to have tenacity and find a way to have time to lead the charge. So next slide, please. And our internet connection, there it comes. Great. So I thought maybe I'd offer just a couple other examples of something that Jody started off with that involved me because of my role with public health. And the first to mention is the 2015 California law, which eliminated the personal belief exemption for immunizations at all schools. Of course, we'd had the measles outbreak at Disneyland earlier in the year, and Dr. Pan is a pediatrician on the California Assembly who introduced legislation to eliminate the personal belief exemption in some communities, that exemption was being used as much as 30 to 40% of the time, so that many schools were largely unprotected from the herd immunity that is so important to save us from infectious diseases. We decided to have a grand rounds. The nurses, the school nurses were understandably concerned about the dealing with upset and angry parents, and we needed to find facts. The primary care physicians needed to be informed about what's a valid medical exemption, and we knew it would benefit them to have a better understanding of the predicament the school nurses had to face. The law required significant data tracking. So, but this was an ideal opportunity for public health to be involved, since it involved immunizations. I think we had quite a successful event, and I think the transition to eliminating personal belief exemptions has gone quite smoothly in our community to the benefit of all. So next slide, please. The next area we tackled was California also had new law requiring schools to meet what had already become standard of care with regard to management of sports-related concussions. And once again, this presented us an opportunity to provide education. And once again, we chose the forum in our small community. We can have grand rounds in a room with a capacity of 30 or 40 people, and it meets the needs. It would be more challenging in a larger community. Nonetheless, we invited coaches, parents, school nurses, providers, all to the table for a presentation on the contents of the new law, as well as a discussion of current guidelines and what had represented standard of care. We took the opportunity to update our policies and procedures. And at the bottom of the slide there, you see some of the challenges that we think are particularly poignant in a rural area, those being coaches with less experience with concussion. We do not have certified athletic trainers who are empowered in the bigger schools to turn the athletes to play. And it's a challenge to sometimes get the metrics that otherwise would be expected of us. So, on to the next slide, please. So finally, and not unexpectedly, and to recap, I think at the extent that we can seek out champions to lead the charge with passion and tenacity, and who can find the time in the interest of our children, we certainly should do that. And of course, interpersonal and communication and communication between groups are essential components. Thank you very kindly.
Thank you, Dr. Satterfield. And our final speaker is Dr. Harold Migalnik. Dr. Migalnik is a pediatrician in private practice for the past 38 years in Phoenix, Arizona. He is a member of the AAP Council on School Health and was one of the lead authors on the last AAP position statement on the role of school nurses in schools. He is the past chair for the physician section for the American School Health Association. He's a recipient of the Milton Sen Award presented by the AAP Council on School Health to individuals who have significantly improved the welfare of school children. Dr. Migalnik.
Well, thank you, Stephanie. And if we can go on to that first slide. My discussion today is what are the practical ways that community pediatricians in suburban and urban settings can work together with school nurses to address the medical needs of children and their families. On to the next slide. My practice is a 15-member pediatric practice, and we're still considered Phoenix proper, and I service children that go to around 15 different school districts, and each school district is entirely autonomous. so that it's a lot of school nurses and a lot of school psychologists and social workers that I have to deal with every day. And what I needed to do was to educate my families that I take care of what my role is in helping them navigate the system in schools. Very often I am taking care of the children prior to the time they even start in schools, so that it's very important to know what is medically necessary from what is educationally necessary for the children. When we take care of children and we start in the newborn period, we usually can define which children are going to require more access to services. And for those first 3 years before the kids start in school, because in our state at 3 years of age, they go from the Division of Developmental Disability for Services to the Department of Education, so that we have to help them make that transition. So we become the advocates for the family in helping them deal with the issue of the transition. I have a personal love for getting involved in schools, and I have attended a lot of the IEP meetings for the children that I take care of. And those are the individual educational planning meetings that are required for children who are in special education. By being at the table, by having their medical advocate at the table, the family feels much more comfortable that the needs of the child are going to be assessed and appropriately dealt with in the school setting. The level of concern goes way down as soon as they see me walk in the room and that they know I'm there to help them acquire the services their child needs within the school. As a pediatrician, I also have to help the parents look at making the school environment safe for their child if he has or she has special medical needs, whether it is the issue of the child with asthma, whether it's the issue with the child with cerebral palsy that requires safety within the school, whether there's G-tube feedings. It's really up to me to help them deal with that. And I use my role and work with the school nurse who really shares what I do outside the school to what she does or he does within the school. Can we go to the next slide, please? There are several things that we do when we're working within the schools. I sign standing orders. Very often the school nurses, and in Arizona, in the school districts that I relate to, there is no other medical involvement within the school. The person at the top of the totem pole medically within the school is either the school nurse or the health aide that is working that school. Very often they require a set of standing orders every year that have to be signed by the physician to allow the school nurse to do what they do within the school, whether it's giving out some Benadryl or stabilizing a child. It all goes by standing orders. Since I have a relationship with so many school nurses, I've taken on that role of helping them get their standing orders signed every year. I've also worked with the EpiPen people in getting into the schools, making sure that EpiPens are available in every school for emergencies. And we go through an educational issue with the nurses to make sure that they are comfortable in utilizing the EpiPens appropriately. What we also need to do is to coordinate the transfer of information both from my office to the school and from the school office back to me. By getting to know the school nurses and very often the school administrators, we feel comfortable in sharing that information and making sure that the parents sign the release forms that make this process available to both myself and to the people within the schools. We have the next slide, please. Pediatric providers also, my office is a teaching area. Very often different residencies will send their residents to the primary care office in order to get the training modules necessary for their residency education. And what I do is make sure that part of that component is to educate the residents about the importance of school health and working within the schools. And whenever I go to school IEP meetings, I usually have a resident with me so they can actually see the process. Because it's been brought back to me multiple times that what residents learn in their residency is how they forever deal with their specialty. So by getting them early, getting that involvement early with schools would hopefully continue their participation with working with schools. I also find that getting the school nurses, by giving the issues with the EpiPens, by going out and doing certain in-services with the school nurses, by attending their general meetings, it gets me known in the community so that the school nurses know they can call me. It also gives them a lead person with the AAP in our state so that we can work together. Because with the school nurses, we have shared goals and we have a mutual trust, and we can effectively measure our responses back and forth. I can get information from them, they can get information back from me. Next slide, please. The rest of these are the issues of resources that are currently available to us. And I appreciate the time to speak with you today.
Thank you, Dr. McGelnick, and thank you to all of our speakers. Before we jump into the audience questions, as Dr. McGelnick said, we wanted to add some resources. Don't feel frantic to write this down. We will be sending this slide set and these resources to you. Everyone who registered, an email will be going out with additional information, including these. We put them in order of appearance during the presentation, just so you have some context. So you see the NAFIN framework, you have the CDC, ASCD, whole school, whole community, whole child resources, the individual AAP policy statements on care coordination, medical home, IDEA, and the brand new one, role of the school nurse. And then you can find all of the Academy policies and additional publications at that website. Also, both Dr. Baker and Jody spoke about the online curriculum that is available. This is a wonderful resource. It's very broken down, and if what you see on the screen, that's exactly what it looks like. You can click on one module, you can click on two, you can download the whole thing. You can break it into pieces for a training or a learning session or a grand rounds. So I encourage you to take a look at that. Just following up on what Dr. McGelnick said, to look into your local school nurse associations or organizations. If you go to that NAFIN website, it will give you all the affiliates and chapters across the country. The same with the AAP chapters, and then the same with the AAFP chapters. And these are just a few additional resources. If you have any questions or on any other comments, our National Center website is there, medicalhomeinfo.org. We have our email address right there. And if you'd like to join our listserv, this is separate than the email that we were talking about as a follow-up to the webinar, but we send lots of information about medical home, care coordination, school nurses, kids with special needs, et cetera, via that listserv. So we do, and it's not, you don't get 5 emails a day, I will promise you that. So if you're interested in that, please do send it, and we probably will be sending that information about Dr. Baker's upcoming publication via that channel, so please do sign up. And then also I just put links to the 2 Academy councils that work most closely with the school health and children with special needs population, the Council on School Health and the Council on Children with Disabilities. So with that, if you just give us a few seconds, we will put together some questions. We are going to look through a few. And yes, the webinar will be archived. You will get an email afterwards that says, please do, it'll give you a link to the archives. Okay. How are schools funding school nurses in each school? Does anybody want to take that question, any of the speakers?
This is Diane. So
Okay.
funding for school nurses may vary greatly from state to state, and there is a complement of funding mechanisms. The first being the local education agency Medi-Cal funding source, which is available nationwide. The second is there is a bill right now that is going to be looking at releasing funding for school nurses at the federal level. And with the Every Child Succeeds, the ESSA Act, there is a call for student support services to be a certain percentage of Title I funds. And I know many school districts across the nation are reallocating some of their federal Title I dollars to support school nursing. Within states, you can look at the community benefits programs at your local hospital. Every single hospital that gets federal funding is required to have population health programs, and in many cases, school nurses have gotten involved in the community benefits program and actually created liaisons and sources for funding in that mechanism. And then there's the local funding that may be available in your community and your district. If you check with the NASN website, they also have good toolkits to help you explain, do an elevator speech, and campaign for school nurse funding. But at the federal level, there's many resources you can tap into.
Thank you. Anybody else want to add to that question, or should we move on? Okay, let's move on. What about 504s and special education? This participant said that she finds a great deal of work with providers comes up with these two areas.
This is Harold McGelnick, and for the children that I take care of, obviously a 504 plan is an accommodation that's made for a child who does not require special education. The IEP, the individual educational plan, is made for a child when they qualify for special education services. There are several different ways that a child can qualify for a 504 plan, but they usually have to get into one of the categories, whether they are in the other health impaired, the orthopedically impaired, the visually impaired. There has to be a reason for them to require accommodation. And those accommodations are requests of the educators to make accommodations in the classroom. It's not a requirement. The IEP is a federally mandated, and it's a requirement that the school has to follow through with it. The 504 is an accommodation. And very often the parents can see if the accommodations are being made, and they then can come back to the school if they feel the accommodations aren't occurring for the 504 plan. But a 504 is accommodations in regular class, does not require special education categorization, and the parents, and it follows the child right through their educational process. So the child goes into college, the 504 can follow them even into college.
Okay, thank you. This is an interesting question. For those of us in communities that have very little success connecting with local pediatricians or family physicians, what do you recommend as the best way to reach out to these providers? $1 million question. Go ahead, Diane.
I worked in a school district where that was clearly the issue. We had some large provider networks, and it was almost impossible to even get connected into the pediatric office. And from that, multiple errors in communication occurred, and sometimes mistakes were made in delivering care for children. And it finally just became so troublesome for me that I went to the pediatric office, and I waited, and I requested a meeting, and I scheduled an appointment to talk to the chief of the pediatric division. And then we began this discussion about communicating with schools. I was invited to one of their lunch meetings and discuss what school nurses need, and very much did what Jody did in her community, was to say, what do you need, how can we communicate, what are the forms, and what happens next. Now, it was a larger urban district, and there were many other care providers, and that worked so well. I took all the forms and everything, messaged them up, went and sat in another pediatric office and said, here's what I'd like to do. And they then could use those same tools and turn around and do it. So that's one way to start. Certainly that community cafe. Invite your providers. Find out where your pediatricians are getting their CEUs. Is there local grand rounds? Show up there, introduce yourself, pass out your cards, have your elevator speech ready. And then here's a big key point. Find a parent or two that can advocate and occasionally go with you and tell their story. Big marketing success that way. But, you know, you don't have to conquer every single thing at the same time. Just pick one.
Very often the other thing, the other thing that can sometimes occur is that each one of these pediatric offices their services are paid for by insurance companies. And sometimes, especially the kids who have special health care needs, might have a nurse coordinator within the insurance company who can champion getting the office to do what the office needs to do, because the power of the purse is sometimes a very powerful modifier.
Great. Thank you so much. These are some HIPAA-FERPA questions. One of the presenters mentioned that new guidelines are being issued regarding FERPA and HIPAA that may help the interagency care coordination a little easier. Could you say more about that?
Yes, this is Diane. So HHS is working with the Department of Education to re-look at HIPAA and FERPA, and this was started as part of the Every Child Succeeds Act and the call for funding from Title I funding to be spent on student support needs. And, of course, the FERPA-HIPAA issue immediately became a barrier. So they are working on it, and I know NASM has been part of that discussion. We're hopeful that that information will be out shortly. And as Stephanie said, we'll get it out through the network if you sign up for the listserv. In the meantime, when you begin to start these partnerships, you can say, here's our FERPA form, here's your HIPAA form, here's why our form says this, here's why your form says that. What can we do to blend these and merge these together? And then there's also electronic health record sharing. The state of Denver has set up their electronic health records to be available for school nurses. They've also done work on that in Oregon, and so those problems have been solved. I would encourage you to just Google Denver School Nurses, EHR, and in Oregon, and find out the agencies that they've been talking to and get some tips about how to overcome the HIPAA-FERPA issue. But don't let it become a barrier. That's not the intent, and it can be overcome.
Any other comments from the presenters on that question? Okay, this is also HIPAA, FERPA, and Diane, if you feel like this is already answered, I don't know if it's a bit of a nuance. Can you give more specifics about what information can be expected to share between the school and the pediatric office? So this would be the MOU and how it addresses HIPAA and FERPA.
Well, I think the nuances of that may be beyond what we could discuss in our call, but if you think about the principle of HIPAA is that you can share among healthcare providers what needs to be shared specifically to the student, and that the forms are easy, explicit, and clear in 14-point font, and following the guidelines and the intent of the law, and the same thing on the FERPA side, and that the parents are part of the partnership in the form development, you'll go a long way toward easing that. But you can share information. That's the big go-home point. so often I am visiting with school nurses and school districts, and they basically just say the pediatric office said they can't tell us anything because of HIPAA. Or by the same token, the pediatricians can't get any information from the schools, and the schools are saying, well, FERPA prevents us from talking to you, and it is not the case. So there's even a report in 2008, which is a joint report, and I'll get it to Stephanie and she can send it out to you, that talks about HIPAA and FERPA in schools and how to overcome these barriers and the intent. Don't let it stand in your way.
And I'd like to add that, again, that whole idea of a point person at the primary care providers' offices is very helpful, because a lot of times that takes you beyond that misunderstanding of the front office staff.
I'd like to echo that too. Very often my front office staff tries to protect me from issues that I don't want protection from, so that when the parents get right back to speak with me, it changes everything. When I don't even know what has occurred because it gets blocked at the front desk.
Okay. What about how do you help parents understand that there may be a difference of what families can do for a child in the home versus what is medically necessary, reasonable in the school?
This is Dr. McGowanlick again. That's a very difficult question, because I think there's a learning curve for families, and they sometimes, especially during those first 3 years of life, the family becomes very comfortable in what it provides at home. When they transfer the care to their developmental preschool at 3, they have difficulty in giving up control. And it requires a balancing act on the pediatrician or the primary care provider's behalf to get the family ready to accept the role and to accept the transfer to the school, but it also requires me to go to the school to make sure they're comfortable in supplying the services that they say they're going to supply. Sometimes there can be a disconnect, and what I ask for might not be exactly what the school is going to provide, but sitting at the table allows the dialogue to occur and the family to know what it should be expected at school.
This is
Okay.
Diane, and I would just like to also add that the school nurse can talk with the pediatrician's office, because many times they simply cannot get the time to get to the IEP. But if they send a very short, concise report, talk to the school nurse can help bridge that gap, develop trust, and represent what the medical home is wishing, and help to balance that. And I think that's really one of the great skills of the school nurse, because we have our foot in both sides of that coin. We understand the medical world and we understand the educational world, and we're in an ideal position to help families have trust in both those systems and communication.
And I only think the one other added issue to that is to the school nurse knowing the limitations of what they can offer by their time restraints. Sometimes the school administrators might want them to do more than they have the ability to do, and therefore we sometimes have to bring in outside nursing in order to provide the least restrictive environment possible for the child.
Great. Well, we have a few more questions, but we have run out of time. I just wanted to say thank you to everyone that participated. Thank you for our faculty members. We appreciate your time and your expertise. And just to let you know, the questions that are unanswered, we will be getting information and answers from our faculty, and we will send that out to everybody, including the people who asked those. So just to let you know, this webinar recording, slides, questions will be archived shortly on our website. You'll receive an email with additional information and a short evaluation. I know people don't like to fill out evaluations, but if there are additional topics under the rubric of school health and school nursing and care coordination. Let us know what you want to hear, and we'll see what we can do. With that, thank you very much for your participation, and please contact us with any follow-up information. Thank you very much.